All the cleanup.
No.
Right here. And then when you're ready to do your slides, you can just.
You are guests of ladies. You're guests of.
Are you gonna introduce us all or just talk?
Oh,
We ready?
yes, to go back to that as our conference.
Yes.
So is it?
Well, good afternoon, everyone. My name is Robert Buckingham, and I've been a professor here for many years, and I'm delighted to be back in town to be able to give you the hospice address. And then Laura will basically give you an address on grief and loss, which she has a recent book out. And I think you'll find interesting. But let me start very informally before I get into the formal slide presentation. The word hospice comes from the word hospitality. And the first hospice was in the medieval times when people were going on the religious pilgrimages. The religious pilgrimages in the medieval times, they would go and stop for respite. They would stop for food, for rest, and they would recover and move on their pilgrimages. This is what was the first hospice back in the 14th century. Now, as I said, the word hospice comes from the word hospitality. Hospice is very different. You all know what a hospice is now. But back when I was a lot younger, and that after medical school, hospice did not exist in this country. So I'm about to tell you a little bit about how it happened, how we brought hospice to the US. You know, in life, you have professional plans, and oftentimes personal events will change your professional plans. And oftentimes, for those of us in the area of hospice, area of loss and grief, oftentimes personal events will dictate our future paths. So with that, let me say, I was never intended to become a hospice person. I thought I was going on to law school or graduate school. But a personal event that occurred in my life, which got me involved in hospice care, was the death of my mother when she was 49 years old. She had breast cancer. It metastasized to the lung, to the bone, and then finally the brain. She was 49 when she died. I came from an upper middle class New England family. Grew up in New Haven, Connecticut. My father worked in Boston. My mother worked in New York City. She was a designer for a company called Christian Dior. And she had a very productive life. She would take the train in every day to New York and come back to Connecticut, 3 hours round trip every day into New York City from New Haven. When she died, my life changed. I had just got out of the service. I spent 3 years in the Navy as a naval officer. Some of my tours were in Vietnam and in Virginia Beach. So I seen some pretty bad stuff. And I realized at that point that I was interested in culture. I was interested in other cultures, other people. And so I thought I would apply to graduate school. And I did. And I applied to Wesleyan University. They had a Wesleyan University, Harvard University PhD program in anthropology. And that's what I got my master's in anthropology from Wesleyan University. But in the time since my mother died, I wrote something. I wrote a note called A Letter to My Mother, Things I Never Said. Now, when you're 21, 22 years old, I was 24 at the time she died. You're a young man, you don't know how to really say things to your family. So I wrote this really for myself, and it was published in a local newspaper, a note to my mother, things I never said. Then it was decimated to basically other newspapers, and it ended up in New York Times. Back in 1971, a woman named Elizabeth Kubler-Ross, Dr. Kubler-Ross, came to New Haven to give a lecture. In 1967, she wrote a book called On Death and Dying. Became a popular New York Times bestseller book. She had read my note to my mother, letter to my mother, things I never said. And she tracked me down. And I was a graduate student at Wesleyan University at the time. And she said, I want you to come to Yale and hear me speak, because I think you have something to learn. She said that to me, I think you have something to learn, and I want to teach you. So I came to her lecture, and I met some people at Yale. And I introduced to two other people at Yale, and the people are named Florence Wald and Ed Dobohall, the dean of the nursing school and the dean of the divinity school. Well, back in the 60s, a woman named Cecily Saunders was a nurse in hospice in England. That's where the hospice first started, in England, at St. Christopher's. She was a nurse, attending to the needs of the dying, nursing the dying. She realized after 5 years being a hospice nurse, because it first started in England in the 1960s, she realized she wasn't serving the total needs of the patient. So she went back to school. She went to medical school and she became a nurse. She became a physician. She wanted to tend the needs of the medical needs of the terminal cancer patient. After she became a physician, she was director of the hospice St. Christopher. She realized she wasn't meeting the social needs of the patients. She went back to school and got her social work degree, a master's in social work. This is Cecily Saunders, probably the most important name in hospice care. And she went back to work at St. Christopher's after getting her social work degree. She was a nurse, became a physician, then went and got a social work degree. And then she went back to work for another 8 years at St. Christopher's Hospice. When I met her, she was a student in divinity school, and she realized she wasn't meeting the spiritual needs of her patients. So she, a nurse, became a physician, became a social worker, became a minister. Now the Queen gave her the OBE. The OBE is the Order of the British Empire, the most highest award you can get. So her name is Dame Cecily Saunders. She married for the first time. She was 77 years old when she got married for the first time.
There's hope for me.
And she has passed away a few years back. And I must say, she was an inspiration to me. And she was an inspiration to many of the English people. So Dame Cecily Saunders is well known. And she was the one that really started the hospice movement back in England. Well, I was at Wesleyan. Yale made me an offer after I met the dean of the nursing school and the dean of the divinity school, saying, why don't you come to Yale, go to medical school, and we'll get you your vet, you get the GI Bill. And they said, well, okay, you also can get a scholarship. We'll make you a doctoral teaching fellow and get your PhD. I said, okay. They said, we'll pay you. We'll pay you. It was a lot of money back then, $18,000, but I had the GI Bill too. So yes, said they'll pay me, and it was a 7-year contract because you go to medical school and graduate school. And I said, okay, what do you want me to do? He says, well, we're thinking of bringing this hospice concept from England over to New Haven, Connecticut, where Yale is located. And I said, okay, but I mean, you're paying me $18,000 a year. What do you want me to do? And they said, we want you to help write a grant. And so from 1972 to 1973, I did nothing more than write a grant proposal to the National Cancer Institute. It was a grant, we originally asked for 7 million. We got, and I was lucky, 5.5 million to start the first hospice, home care hospice, back in New Haven, Connecticut. This was 1973. Okay, so I became the director of research of the first hospice in the US. My PhD dissertation was to prove that hospice care was better than non-hospice care or traditional medical modalities. So I did a study, a 3-year study, and I studied basically pain control, depression, anxiety, and social adjustment. The hypothesis being that hospice patients have less pain than traditional terminal cancer patients, that hospice patients had higher levels of social adjustment than traditional medical patients, hospice patients, non-hospice patients, that hospice patients had lower levels of anxiety and depression than non-hospice patients. So I did this study. I interviewed in the study probably about 800 patients with cancer that were involved in hospice care, our first hospice, and non-hospice. Those are people who were at UM-Flint Hospital. Now, that's the hospital my mother died in. So it meant something to me because the way she died was not a good way. She was hooked up to a feeding tube and she lingered on for 4 months. But we don't do that. And thank God we don't do that anymore. So that's how it started in the US. It started basically with 2 people, Dr. Florence Wald and Dr. Ed Doval. And these were the people that were instrumental in starting first hospice in New Haven at Yale University. And because I was nothing more than a lowly graduate student, they made me involved in developing the research to prove that hospice care was better than traditional medical modalities. So with that being said, if there are any questions, feel free. There'll be a question and answer session afterwards. But if there are any questions, feel free to ask. Now I'll start the formal presentation and we can go through this. I think it's the right one, right? No?
So did your doctoral
It says no.
involve
Doesn't work.
impersonating a patient?
No, that was a study I did later on where I lost a lot of weight, posed as a terminal cancer patient. And I got a lot of press because that was one, when we first started the first hospital in Canada, and I was involved in the Royal Canadian Hospital in Canada, Royal Vic. We had I posed as a terminal cancer patient. And we wrote a paper called.
That was written up in the New York Times. So when I was living in Florida,
Yeah.
I saw that article.
Yeah.
And then when I met you again, I said, I remember you.
Yeah.
You're the one that article was written.
Yeah, it was the New York Times, Washington Post. It was sort of a very controversial. So we're having little technical problems, so.
That's okay, you can go ahead.
Is it working?
We're working on it.
Okay. So let me start out. First slide would be great. Oh, we're working on it. Okay.
Can you make
Okay.
this one?
Yeah.
Okay, that's the first one, good. Okay, here's the aspects I'm going to talk about in hospice care. One is to talk about the history of hospice care. I talked a little bit about it in my opening comments, but then we'll get into the foundations and the principles of hospice care. Then we'll go on to types of hospice care programs in the US. Then I'd like to focus a little bit on pain and symptom control. There's a chalkboard I can use that too. I'm not sure.
Whiteboard.
Whiteboard there, right.
Yep.
Use that too.
Markers.
Okay. And then we'll talk a little bit about, just a little bit about hospice care for children, one of my earlier books that I wrote with Dr. Kubler-Ross, was a spoke of kind of love and care of the dying child. And I can talk a little bit about that if you're interested. Questions are really, I'm happy to answer any questions you might have. And then we'll talk about the future of hospice care and how it stands and some of the issues facing the future of hospice care in this country, but also other countries. Okay, can we go on to the next slide? Is it working? Okay. Is something I can push or you want to do it? Okay. Okay. Learn about the history of hospice care from 1970 through 1977. And that's when we first started the first hospice of Connecticut, New Haven. That's where I was the director of research of the first hospice. And the study to prove that hospice care was better than non-hospice care. So those are the years I was their director of research. I finished my work at Yale in 1978. And so we'll talk about 1977 to 2024. In the time, New Haven was the first hospice. Okay, I helped start at the time after it became successful, 5 other hospice programs. One in California, one in Florida, one in Massachusetts, one in New Jersey, and one in Arizona. In 2023, according to the National Hospice Association, now in this country, there are 8,763 hospice programs. Now, what's important, and I'm about to say, is that there are some very good ones, and there are a lot of very poor ones. Okay, and we can talk more about this in the benefit proposal. There's a reason. Back in the 70s, hospice was non-existent except for these pioneer programs. This one here works? Yeah. Okay. Except for these pioneer programs. And in the 60s, okay, no one really knew about hospice. In the 70s, no one knew about hospice. The hospice become really a word until we were able to convince the government to pay for hospice care. That was done in 1981, when my dissertation was finished in 78 and approved that hospice did patients that had lower levels of pain, lower levels of anxiety and depression. And so what happened very simply was Medicare, a lot of us went to Washington, we lobbied on trying to get it reimbursed. And we did. You know, basically Ronald Reagan signed the bill in the 80s to make hospice care reimbursable care under Medicare. And also private insurance companies will pay for hospice care. So now every American who has Medicare can get hospice care free of charge, provided they go to a non-profit hospice. Because guess what? We have for-profit hospices, which I've been historically critical of. So what is the philosophy of care? Well, hospice is a humane, a sensible approach to terminal illness, combining simple care, comfort, and support for family and friends as the individual faces death. So the big change here in hospice care is that we don't treat the patient alone. We treat the patient and the family members and friends as the unit. This is completely a new philosophy. Before, you know, in medicine, we have a patient, we have a doctor, and we have the institution. Now, our goal is to treat the patient and the family as a unit of care. And I think as Laura will talk about later, about what happens to the family after the death of a loved one. And so this is the basic philosophy of hospice care. Now, people get the words palliative care and hospice care mixed up all the time. And they're different. Okay, palliative care combines all of hospice care, all of it, philosophy of care, but it also looks at curative treatment. Okay, it looks at what else can we do, whether it's chemotherapy, whether it's something else, what else can we do to stop the progression of disease? Hospice care only focuses on the last 6 months of people's life. And to get into a hospice program, a primary care physician must give a recommendation that you have 6 months or less to live before it becomes reimbursable through Medicare or insurance. And of course, you'll hear more about, I speak most about grief and loss and bereavement care. And hospice has a bereavement program in their philosophy of care. And I'll talk a little bit about that. The question is, what do dying people want? And worked with now over 4,000 terminal cancer patients in my 50 years of being a university professor. And they want two things. They want truth and they want time, more time to live. That's what people who are dying, that's what people want. They want more time to live. So truth from the medical care establishment and time, so they can come to closure with their family and loved ones. Now, a lot of people are afraid because one of the chapters of my earlier books, and the chapter's called To Tell or Not to Tell. This was a big decision. When someone is terminal, do you tell them that they should get their house moved because they have months or weeks left in life? So this is the two things they want. Everybody wants more time. We all want more time. And we all want the truth. And if you ask yourself the question, if you were to be given a terminal diagnosis, what would you want? These are the things you want.
But where does pain control fit into it?
I'm going to get into it. Okay. Now we'll talk about pain control. Maybe I can use this chart with you. The foundation principle of hospice care. Well, first of all, it's medical care. Remember? Leslie Saunders, she became a nurse, and she became a physician, and then she became a social worker, and then she became a minister. So it's medical care, nursing care, spiritual, psychological care. And now we're looking at nutrition. This is a whole different area now. What are nutritional needs of the terminally ill? And everybody's exploring this because there are different needs, from hydration to protein. And so there's a lot of research right now being done in this area. But the most important thing is on the bottom of this slide. The patient and family is the unit of care. That's the most important thing. Excellent. The following principles will basically come to appropriate care for hospice patients and their families. We'll go into principles, and soon Dr. Stick will come up with the answer to your question. Talk a little bit about pain control. It's very different, pain control with a terminal cancer patient than it is with non-terminal cancer. Does that thing go away so people can see that?
For the next one. Exit up.
Hit the X, maybe you'll see it, yeah. Great. So, again, the concept of patient and family's unit of care. There's some photographs. Patients and their families. Mostly at home. Now, when we first started the first hospital, it was home care. I did all the visits, my interviews, I would go to people's homes. Now they're inpatient programs. And I was very much against inpatient programs in the beginning because I didn't want to have what I used to call in my book, an edifice complex. You have to have a building to have a hospice. Hospice is a philosophy of care. It's not a place. It's a philosophy of care. Hospice patient needs to be as symptom-free as possible so that his or her energy are used to live the remaining portion of their life as fully as possible. That means communication with family. That means communication with loved ones, with friends. Another concept of hospice care is doctors and nurses must easily be accessible to patients and to family members. When we first had the hospice program in New Haven, we were on 24-hour call. The hospice doctor or the nurse would be out there at the home whenever called. We had one hospice doctor, 5 hospice nurses, and we had a minister, and we had a social. So, and we were all on call. If family was in a crisis, the doctor would go out. Okay, so that's an important concept even today. Accessibility. Accessibility is critical. The continuity of care should be sustained by the same team. If you go to the hospital today, I just spent some time in the hospital. What happens is everybody comes and goes. You don't know who takes care of you anymore. You have a nurse in the day, a different nurse at night, a different nurse, a different doctor. You got a hospitalist. You have, it's fragmented. The problem with the healthcare system, it is totally fragmented and it doesn't address the need. We want to see the same doctor. We want to see the same nurse. Let's have them become part of the family. We call it a hospice. And oftentimes I remember when our patients died, all of us would go out to the funeral. That doesn't happen. We become part of the thing. We become part of it. Another concept of hospice care is the patient's family and lifestyle should be maintained and their life philosophy respected. I learned this lesson back in 1982, 83. Back then, if you remember, some of you remember, some of you won't remember.
I'm trying to remember.
Exactly right. You weren't born yet. Okay. But we had a big disease back then. We didn't have epidemic. We had HIV back then. And I remember being asked to develop a hospice program back in 1982. Go down to Key West, do a hospice program just for gay men with AIDS. That was back in 1982. And I eagerly jumped on that plane, flew to Miami, drove down the causeway to Key West. And we started a program just for gay men, okay, and their families, or their loved ones, so that they, because back then in 1982, 1983, you came down with HIV, you had 2 years to live. 2 years was the max amount of time you had to live. It was a death sentence. So the last 6 months of life, and if you know anything about the Key West, about 30% of the population is gay. So back then, it was important. It still is important today. And this thing of respecting the lifestyle is very important for hospice people. Next one. These are some of the issues. I think maybe Laura will talk about this especially in grief, but also people who are dying, feel these things, loneliness, isolation. The greatest fear that people have when they're dying, the greatest fear is not dying. They don't fear death. They fear being abandoned. That is the greatest fear people feel, being left alone. Okay? And there's nothing more frightening than being alone. Being alone. There's nothing more frightening. We have found out in our studies that if you have pain, you're alone. Talk more about pain coming up. Pain increases. Pain increases when the patient's alone. Why is that? Well, I'll talk about it in a bit. Okay. So we go on here that professionals and lay health caregivers must be prepared to address the problem when it surfaces. Loneliness, isolation is a real issue with people who are dying. Not just the dying, but also the family members. The person who loves the person who's dying. They fear being left. Think about it. And you can talk about, maybe we'll talk about anticipatory grief. You know you're about to lose your mother or your father, and all of a sudden you anticipate that grief, that loss, and you start feeling alone. Well, you're not alone because the person is still there. And we see this a lot in hospice care, that the family members sort of isolate themselves from the patient. They move away. They use excuses like, well, I don't know what to say. I don't know what to do. These are the things that usually happen. Okay. Well, we have to erase those things. We have to focus on how do we reduce loneliness? How do we reduce isolation and the fear of abandonment? Because those are the three elements. Those are the devils in the detective. Ethics. Well, hospice care has to do with making choices for the terminal patient. Ethics is about choices. It's about values driving choices. Ethics are really important in all of medicine, in everything we do. And hospice has a certain code of ethics, and we can talk more about it if you like. So ethics are very important. The notion of hospice resists simple definitions. That's because hospice itself is a moral notion. It's compassion. We look at today's society and we look at Congress, we look at the Senate. What do we see? We see chaos. What we see is lack of civility. That is one of the biggest problems we face in the world today, especially in the US, is lack of civility. Why can't people be nice to each other? Well, in hospice care, it's important to be nice. In all medicine, it's important to be nice. Hospice patients should be treated as a person. So it's Mrs. Smith or Mr. Smith, and not my cancer of the pancreas patient. They're not a disease entity to you. They're a person. You got to bring the person back into the patient. What does this person do? What are this person's life? How do we find out more about this person? Because if you find out more about this person, you're going to be a better caregiver. You just can't treat the person as a disease entity. You can't. You got to treat the person. You got to find out about this person. So one of the things we do with our hospice, even our hospice volunteers, is we train them to ask certain questions to bring the lives of the hospice patient into their life. And this is part of any of hospice programs they're volunteer. 24-hour care, accessibility is part of hospice. You have to have 24-hour care. Whether that means 24-hour care bedside, or that just means accessibility to someone coming out when things go out of control. Okay, things go out of control. Humanistic care should be integrated with expert medical nursing. Is that me? I don't know. Turn this off. Yeah, so. Let me turn this off. So humanistic care should be integrated with expert medical nursing. You have to be human first. You have to understand what the other person is going through. You have to put yourself, you know, the whole saying, you know, don't judge me until you walk a mile in my shoes. We have a tendency not to think about our own selves, and we don't put ourselves in the shoes of the other person. Once you do that, I think oftentimes understanding civility will occur. But we think we have our own goals, our own agenda. And in hospice care, it's nothing but your own goals, your own agenda. It's the patient family's goals and agendas that you should consider yourself with. Family facing impending death, a loved member needs support and advice from healthcare professionals. Families are looking, especially at this time, from support and advice from doctor, nurse, a social worker, a volunteer. They're looking for help. And what they're saying, consciously or subconsciously, help me through this. What do I do? What can I do? How can I make this a better experience? These are the questions there. Family must feel a sense of participation in caregiving and decision. I have a patient right now that I'm seeing in Hawaii, and she was a flight attendant for many years, and she's dying. And what we're doing is she makes the decisions. She makes the decision. Okay, even though sometimes the family doesn't like the decision. Okay, she makes the decision. She is the captain of the team. So and then oftentimes there's conflicts, there's interfamily conflicts. Because what the patient wants may not be what the family wants. Okay, and this happens. And this is happening with this woman that has probably, I'll be back in time, probably 4 more weeks to live. There was a slide on pain control. Did we miss it? Was it up there?
Not yet.
Not yet? Okay. The primary care person tending to a hospice patient at home needs support and occasional relief of duties from dying person. We call this respite care. We identify someone in the home. We call them the primary care person, PCP. Someone is responsible for the care of the hospice patient, whether at home or whether basically in the hospital or in the hospice, the patient hospice. Someone is in charge. Oftentimes we like the patient to be in charge. There comes a time when they are unable to be in charge. So someone is in charge. We need to know who that person is. That person who's in charge needs relief. That person who's in charge needs a break because it is overwhelming caring for someone who is dying. It is a 24/7 job. You're going to get tired. You're going to get angry. You're going to have fights. These are things that happen. So they need a break. And so we make sure in hospice care, when we see this occurring, we make sure they take a break. We get them out. It could be even just for 4 hours going out for dinner. or being with other family members, or going to a picnic. Just get them away, just for a short time. So the PCP, primary care person, needs respite care. After death has occurred, and Laura will talk about this, the surviving family members need special care and attention from the hospice team. Hospice team, what we do in hospice is after someone dies, when someone dies, there's a funeral, there's a service. Everybody comes around, family, friends come around. You know what happens? 3 months, 6 months afterwards, no one comes around anymore. Okay, and this is where bereavement care, grief work comes into it. Well, I'm sure we'll talk about this. They're forgotten because we're all forgotten. So there are special needs that must be met from the hospice team. What we do is the volunteers will call up the family member, okay, who's remaining after 3 months. And they say, how are you doing? How's Sarah doing? How's Ben doing? How's Bob doing? And we get a report. This is follow-up care. Remember I said the patient family unit of care? You don't lose the family as a unit of care when the patient dies. The care continues. For us in hospice care, it's for 2 years. We do an assessment in 3 months. We do an assessment in 6 months, 1 year. And then at the end of at the 22nd month, we have another follow-up. 4 phone calls. Could be in-person meetings, whatever is needed. So, and then then they're discharged. But hospice care goes on 2 years after the patient dies. We talked about the family unit of care, it is socially, we talked about bereavement programs, so we'll talk about that next. And I'm sure we'll talk about how to reduce unhealthy behaviors from the grief reaction itself, because there are unhealthy behaviors. Some people may drink too much after the death, some people take too many drugs after death. All these things occur. Okay, 3 types of hospice. 2 types of hospice care. I said, profit and none. Okay, I've been familiar with mostly non-profits. Why? Because for-profit care, unfortunately, in this country, our healthcare system is based for profit. Many for-profit hospices basically were able to get equipment free of charge from the government. That's what happens. Free of charge. They get the equipment, could be a bed. It could be a special hospital bed. Okay, it could be a hospital bed pad that makes them so you don't have one of the things of being in bed too long, you get the Hughes ulcers. Could be anything. But that's all free with hospice care, except you're a for-profit. You charge the patient this. So often, for-profit hospices are not really ethical. It's a hospice care, but they're charging the patient or the family or the government. Okay, there's a lot of fraud that we find in our healthcare system. And with the for-profit hospices, we find fraud. And I can talk more on this. So there's home care, 4 levels of care, inpatient care, spiritual care, and respite care. Those are the components of hospice care. And we talk about palliative care versus hospice care. Again, palliative care versus easy pain discomfort. We talked about basically that as simply looking at how to reduce the pain and discomfort. And hospice care when there is no possible longer result of cure. We know there comes a time when cure is not possible. So that's what hospice care is. That first slide about palliative care and hospice care. This is the second slide. Okay, here we go. Now I'm going to use the chalkboard, and if I can. Which is, can the people see me or not?
Yeah, you can.
Right? No, this is easy. Let's talk about pain. When you have pain, you usually take something for pain, right? So you have a headache, you take an aspirin or an Advil. Okay? That headache, is that good? Okay. So want me to work here?
Yeah, you brought it back over before.
Okay, great, thanks. So in medicine, we have a thing called PRN. PRN is Latin. Okay. It means, basically, it's a Latin term, it means you give it medication to the patient whenever it's needed. So you get a headache, you take an aspirin, headache goes away, great, headache comes back, guess what? You take another aspirin. Same thing with pain. So we treat pain on a PRN basis. That's how medical professionals, doctors, nurses treat pain. We have pain, you get medication for it. Take you out of pain. Pain comes back, take medication for it. That's how we've done it for years. Well, hospice is different. You're in a hospice program. Oh, just too far.
Okay.
Are you,
Yeah.
Yeah.
is this here good? Okay. So let's look at, so this is, you know what this is? This is our philosophy. So you have pain. Pain is going to be down here, okay? Below this line. Pain is occurring. So then what you want to do is you want to control the pain, right? So this margin is called pain control. And this last margin up here, what happens sometimes, it's called sedation. You go out of it. You know, you take too much pain pills sometimes, you go to sleep. You're sedated. In hospice philosophy of care is, we can't use the same medical philosophy of PRN. When you have pain once here, then, okay, you get some medication, so you get an RX, good, you're in pain control. Guess what happens? Go back into pain, more RX, okay, guess what happens? Pain control. Your seesaw. Well, guess what happens here? After days of this, or weeks, or months, people realize the pain medication they're taking, they know it's gonna last so long. So what happens is the anxiety increases because they're thinking, I know pain's gonna come back, because it always has come back. And so as their anxiety increases, guess what happens? Their pain increases. Their perception of pain increases. And so we've got this seesaw medical model that does not work. That does not work for hospice patients. There's no reason for a hospice patient to be in pain. So what we do something a bit different. Sometimes it can be controversial. If someone mostly in hospice, we use oral morphine. We take it by mouth. And if you know anything about oral morphine, basically, you take it by mouth, it goes through the gastrointestinal system and gets dissipated in the body. Well, it takes a longer time, and there's an absorption factor in the gastrointestinal system. The absorption factor is about 50%. So the person taking oral pain control medications, they're really getting an effect of 50% of the dose. What occurs here is we don't want the seesaw effect happening with hospice patients. We don't want them to go in and out of pain. So what we do, we look at the very simple thing. We look at the body weight. We look at urinary output. Look at organ functions. Make sure all the organs are functioning. These are things we look for. We have basically a table that we can basically prescribe medication, strong medication, control pain. First thing we'll find what happens is we're gonna put the patient, because the patient's been in pain most of the time. So I'll tell the family, you know what, they're gonna probably sleep for 18 hours. We're gonna let them rest, because their body is tired from fighting pain. The body is tired. It wears you out. And so what we want to do, we'll sedate the patient. We'll let them sleep longer so the body can rest. Okay, then the patient will come down and they're functioning, they're coherent, they're talking, they're communicating, they're living life. We want to keep the patient in this very narrow margin. Here, guess what we do? We give them medication prior to the onset of pain. We don't do it here, we give it here. We give it before the pain starts. We give the medication before people, so they don't need it. They need it, because we're trying to keep the patient in this very narrow margin of pain control. And this changes, you guys, this changes the patients every week. I mean, it only lasts about a week. We have to monitor patients very carefully. So we have to really try to keep them in this little narrow margin of pain control. And so whether we're using Oromorph or we're using Dilaudid, whatever pain medications we're using, we want to make sure they get the pain medication before the onset of pain. This is the most critical important of pain control for hospice patients. Medications must be delivered before the onset of pain so that we keep them in this margin of pain control. Any questions on this? Yeah, go ahead.
How many patients tolerate morphine?
Okay, it all depends. We have a formula. And I work with a clinical pharmacologist, and basically we decide what drugs we're going to use. We look at the patient's body weight. People with cancer lose weight. Okay, so we have to look at body weight. We look at bodily function, urine output, look at communication. We have a scale. Like usually we have a pain scale. What's your pain level between 1 and 10? We have a scale. We ask patients. And so we can monitor their pain by them telling us what pain level they have, or they're not in pain. And then we're happy because we want everybody to be not in pain. So whether it's we start them out with 10 milligrams or 50 milligrams, it depends on the patient, side of the pain, type of the cancer, body weight. Okay, so we have a nice system that, you know, the system changes because it can change every day. So it depends on the patient, depends on their tolerance to pain too. I mean, you look at different ethnicities and there's different pain thresholds people have. Some people, you know, I've seen people with very serious stomach cancer, which is the most painful cancer, stomach cancer or bone cancer. There's nothing more painful than that. There's nothing more painful. I've seen patients who say, I'm fine. And I've seen patients in fetal positions and they're in excruciating pain. Pain it depends on the person. Oftentimes people who are very anxious people will have higher levels of pain. Okay, people who are very stoic can deal with pain. It depends on the person. If we look at the person and we look at what they're complaining about, and then we tell them, okay, we have a formula. We're going to change this as we need to. And if you need more medication, we'll give you more medication. You need less. People always say, well, you're making this a big criticism of hospice at the beginning. Not anymore. I remember back in the 70s, they were saying, you're making addicts of your pet patients. Yes. Some of our patients become addicts. Okay? But when you have 6 months or less to live, what's important is that you're addicted or that you're communicating with your family members and telling them you love them. That's what's important. Okay, so those of us in hospice care are really not concerned about addiction, but then I'll take another point of view, saying, I say with hospice patients, we give them less medication because people don't anticipate the return of the pain. This anticipation comes right in this level here. So if you're not anticipating the return of the pain, your pain's going to be less. So oftentimes we give less medication for the end of the patient's life to control the pain than we do in the beginning. And that's a problem too. Do some of our patients become addicts? Yes. I think it goes back to what I said. This is a philosophical question. We're about humanity. You have a dog or a cat, and you love your dog or cat, and most of us, see our cats or dogs, in pain, we try to control, but sometimes there's a time that you put them to sleep. We don't do that in hospice care. We're against it, but we are not against using heavy medication, drugs, control pain. And yes, some people become addicts. We say, so what? Yes, well,
I just want to make a comment. Meds are often used when there's terminal restlessness,
Right.
we can see as professionals coming on in a patient, and yet the family doesn't have knowledge of, what's going on. But they try to make it comfortable for the patient and to protect the family from seeing as the organs are shutting down. And for some people, like you said, especially if they're an anxious person to begin with, they may try to get out of the bed, they may do all these things in the middle of the night, and we don't want to strap them down and restrain them. So instead, we control that by giving more.
exactly right.
Yeah.
Exactly. Because there's a point sometimes, and we can tell the end of, I'm doing with a patient last week, I sort of had to tell the family, the doctor said the patient would live. Well, just so you know, I talked about Jimmy Carter. You know who Jimmy Carter was? He was the president.
What?
I got involved. Was
Isn't
the
he still
president.
living?
Yes.
Oh, you said you know who
Well,
Jimmy
he
Carter
was the
was.
president.
Okay.
He was the president
Yeah.
of the United States, and he was in hospice care. Well, he was in hospice care for a year. We only keep patients for 6 months, then we discharge them. And he was totally, because of his philosophy, I think his religious beliefs, he was an easy patient to take care of. Okay, we thought he had 6 months left to live. Well, Jimmy Carter is beyond 12 months in hospice care. And basically, the Prince Georgia Hospice Program has discharged him because he's no longer in hospice care. Maybe they're following up on a weekly basis, but he may go back into hospice care. But most of the time, people die within 6 months. And oftentimes, one of the issues we have in hospice care is we don't get the referral at the end when a person is really close to death. And hospice can't do their magic when you have 3 days to live. So hospice becomes a dumping ground for terminal cancer patients. Because what? The medical system in the US, we charge, right? Whether you're charging the patient or you're charging Medicare, you charge. So a doctor will have a tendency to keep the patient as long as possible, and then at the last moment, give the patient hospice care. One of the biggest, and I'll talk about the future of hospice care, is physician education. It's nursing education. I wish there was a mandatory course for all physicians and for all nurses on hospice care, hospice treatment. There is one university has it, one I went to, Yale University, has basically a 2-hour seminar. Every medical student must take this class, a 2-day seminar that every medical student must take before they graduate. It's a 2-day seminar on hospice care. We don't have it in this country because we're trained, physicians are trained to cure. And when cure does become available, they look at death as a failure. Well, death is not a failure, you guys, but to them, they're trained to cure. That's what they're trained to do. Just like there's been medicine and public health. Medicine is the treatment of disease. Public health, what we're concerned with, all of us here, we're concerned about not just the treatment of disease, we're concerned with prevention of disease. Well, this hospice philosophy is the prevention of pain by using pain control theory of not PRN, not Bereavement, as in the writings, not them, okay, before, long before, yeah, well,
I was just gonna say, I don't know if you're aware of, Art Buchwald, he was.
Art Buchwald, yeah.
Yeah, yeah.
Art Buchwald lived in Martha's Vineyard
Yeah,
and he died, and he wrote about hospice, and he lived in Martha's Vineyard. I had a home in Martha's Vineyard at the time. And I talked with him 4 times before he died.
And he lived long enough,
He
so
lived
he
long enough,
checked
right.
out of hospice.
He checked
He
out.
was a political,
Yeah.
he was a humorist.
He was
wrote for
humorous. He was a
Washington Post.
humorist.
Yes,
Yeah.
and he checked in, and he had so much social connection and visitors.
Right.
That's what I think made
what you
him
need.
live.
That's right.
And he checked out and he lived long enough to write a book. It's too soon to say goodbye.
Right.
Loved
Yeah,
it. I have it on my book
No,
somewhere, but
And he was a magnificent guy. He
yeah.
was a humorist, and he had a great sense of humor. He wrote for the New York Times and
Many
Washington
other
Post,
things, yeah.
and it was just superb.
I thought of him when you
Yeah.
were talking about.
Yeah.
Jimmy Carter.
So, and laughter, laughter is a very important part of dying. Okay, in a sense. When someone is dying, either your family member, either crying or you're laughing. The emotions in this time of life is so strong, the family, that either you're crying your heart out or you're laughing over stupid stuff. And because we laugh over stupid stuff or memories. It's just the way it is. It's a very intense time for everyone involved. And you know what? That for many families, you guys, I'll talk about this, Laura will maybe talk about it too, it's a coming apart issue. It tears families apart. If someone dies, oftentimes the family's not the same anymore. The family unit's not the same anymore. And what we try to do is keep the family together as best we can. We can't, that's why we have social workers. We have doctors and nurses are not trained to do any of this stuff. We have social workers and bereavement counselors and Laura will talk about this. So any more questions on pain control? So, yeah. And you move on.
What time did yours start?
For what time?
After what? After break.
After the break. We'll take a break after the.
Okay.
Okay. I'm almost done. Hospice care for children, I keep this short sweet. The important aspect of hospice care for children is because the first thing when I have a child, parents, mothers and fathers say, take care of my kid. They really go like this to the medical care institution and say, save my kid. And they don't get involved. They think we, those of us in healthcare professions, can do miracles. Sometimes we can, sometimes we can't. But we must keep the family involved. Make sure the parents stay involved. Because let me tell you something. When a mother and a father who are married have a child, the child is below 10 years old, the child dies of leukemia or below 12. The child has a leukemia or cancer, the chance for divorce is 75%. 75%. Why? 3 things. It went together. It wasn't supported. 2, what if the parent, what will go inside? If you lost your child at 5 or 6 years old, you're gonna blame what did I do or what didn't I do? Why didn't I take her to the hospital early? Why didn't I have this doctor look at it? It is the sins of omission that parents feel. What did I forget to do? And all of a sudden, communication between husband and wife start deteriorating. They start to go their own separate ways. Divorce. Normal divorce is 50% you get. So the other thing, if you get married, it's a 50% chance that it'll work, 50% chance that it's not gonna work. So that's statistically accurate in the US. But when parents lose a child who's under 12, divorce is a real reality. Okay, and so what we try to do is, one, keep the parents involved. Two, let the child be a child. Let the child be a child, enjoy it. Let the child laugh. Do everything you can to make this child a child, however old the child is. And then, Laurel, what you'll talk about is very important.
Yeah, with the parental bereavement, oftentimes they grieve very differently,
Very
the
different,
man and the woman.
very different.
And that causes problem because one thinks you're not grieving enough, or
Right.
you don't really care. And the other one thinks you're being extreme. And so I'll
Right.
talk about that. It's the intuitive griever style versus
Exactly.
the intuitive versus the instrumental
Right.
type
Right.
of grief. So,
Yeah, and men and women do grieve differently. I mean, men have a tendency to keep things inside. Women have a tendency.
typically,
Yeah,
Right.
a tendency.
yes,
That's all I'm saying.
yeah.
And women have a tendency to be communicative, be more open, usually. I'm not saying anything different. I'm just talking, anyway. So the future of hospice care. Well, as talked earlier, it's basically about physician education. It is about basically training physician or medical students today about what hospice care is. And guess what? I've written 3 proposals, all failed to bring hospice in the curriculum of medical students. All to Stanford. This is the University of New Mexico. We tried it there and it shot down. They said we can make it a volunteer thing, unless it's required. Medical students aren't going to take a class. They have to take it as required. But that's the way, medical school is. Nurse education, I think in nursing, they should learn about it. So there are more programs in nursing schools than are in the medical schools. So, but they still lack it. Hospice care still lacking. Early admissions and late referrals. This is about the future of hospice care. We need to have hospice patients be referred earlier, not late. When I talked about earlier, we get them too late in their last stages of life. We need to know 6 months before. And a physician can refer a patient 6 months before they think that a person will die in 6 months. Most of them we can tell. Okay. And they need to make referral to hospice care. And then combating misconceptions. There's so much misconception about hospice care and about dying that we have to inform the public. It's getting better, but there's still a lot of work to do. So these are from one of my earlier books. Will always be among us. We should never escape it. It's simple as that. It's reality. We're all going to die. It's funny, we just had the solar eclipse and people realized, who saw the solar eclipse, they realized how small, how insignificant they really are in the light of the universe. Okay, and it was a very moving thing. So dying is part of the process of living. We must not fear it, we must not hide it, we must not ignore it, we must deny it. Death is. This is from my book called Hospice Guide. This is from my book called Special Kind of Love, Care of My Child. The greatest tragedy in life is not that we're going to die, but that life is not fully. So all of us have responsibility to live our life fully, not to get sort of bogged down with the mundane trivialities and then get upset by trivial stuff. What's the importance of your life? What is it you want out of your life? Where do you want to go? What do you want to do? There's a lot of places to go. There's a lot of things to do. And that will end.